Anyway, I'm going to talk about evaluation of the infant with diffuse lung disease, and I said best practices because that's what I was told to talk about, and I'll try and do that. Just to let you know that this is my favorite slide for any difficult issue. The road to enlightenment is long and difficult, which is why I asked you to bring sandwiches and a change of clothing. You're going to get lunch after this. You may or may not need a change of clothes. But and by the way, I want to point out, we don't have a pointer here, but just to let you know, this is not me. It kind of looks like Leland. If it was somebody carrying pom-poms and cheering us on, it'd be Robin. But I'm one of these guys. And I think that one of the humbling things about this is that I think a lot of the times we all feel like we're still learning this, and I think we, the clinicians, should keep that in mind, because we are really all learning this. And you're very important to us. We can be seen as important to you, but you are very important to us to do this. So let's see, how did you all get here? How did we get here? Well, I would propose that somebody recognized that their child was just not right. Something wasn't right. Their breathing wasn't right. They're breathing too quickly. They were found by their physician to be low in oxygen. They would listen to the child and they didn't have the right sounds. Their chest x-ray didn't look normal. Something wasn't right. And I've seen this all too often. By the time I see the patient, they've already had multiple attempts to treat the abnormal symptoms, but these attempts were not successful. And somebody had to realize that the something not right, whatever it was not behaving or responding to treatment in the way that the physicians expected or the parents desired. So I suspect that's, for a lot of you, is the way you get here. We've all seen this, that child diagnoses are actually part of a larger group of abnormalities. They're not, there's a whole slew of these. It's a rare heterogeneous group of lung diseases. They are difficult to diagnose. I can say that from personal experience. Some of them are very difficult to treat, and the prognosis, the outcome is variable. Some of these entities are known by us, we feel, to be pretty benign in the relative sense, and others clearly are not. You've seen this before. The colors are weird, but anyway, there are diffuse lung diseases as a general family, and this child syndrome here with some specific diagnoses that we know. Many of you in the room have a specific diagnosis for your child. Some of you don't. We hopefully eventually will get a diagnosis. We will eventually enlarge this to fill the child syndrome. But we're not there yet. So what is our task? Yes, I know this is about diagnosis. I know I'm supposed to talk about best practices, but I think we, the physicians, the families, have a job working with the Child Foundation. I would ask you some questions. Is it to help parents and physicians know more about specific child entities, NEHI, SBC, ABCA3, those things? Is that what we're supposed to do? Are we supposed to help out the physicians who send us patients the opportunity to better recognize patients who have child syndrome so they'll know to send them to us sooner? Is that our job? Or are we going to provide guidelines for the evaluation of these infants and children with these problems to improve the likelihood of our getting to an accurate diagnosis more rapidly? And I would offer that I think our job is all three of these things. I mean, I think we, not just the physicians, but all of us have the job to spread the word about what these entities are, because that's the way these children are going to get recognized, finally diagnosed, and all of us will learn about making it the evaluation process more streamlined and effective. Well, best practices. We talk about best practices a lot in the news. What is it? Evidence-based medicine, or best practices, were first coined in about 20 years ago. It was by a group of physicians and epidemiologists. Anybody know what an epidemiologist does? Raise your hand. No? My father was a world-famous epidemiologist. He was. And these are people who look at patterns of disease and locations of disease to try and ascertain or deduce the cause of the disease. So my father did that for neurologic diseases. He was famous for that. He was the father of neuroepidemiology, which makes me the brother of neuroepidemiology, because I know my genetics. So there. So the original, that was an aside, sorry. The original description provided by this group of physicians and epidemiologists at McMaster University was as follows. You have a physician who has a patient with a particular problem. We'll say, how about diffuse lung disease? That's a good one to start with, just a guess. So the physician's job is to search the medical literature on the subject and find those articles relevant to it. Could be 2, could be 200, it could be 2,000. This is how they wrote this. I'm not making this up. The physician would then select the best articles and carefully evaluate the research done, determine the validity of the research methods, and decide what he should do with that patient. That sounds pretty good, right? Everybody agree? We're all right? This is while the patient is in the exam room, by the way. And as you might imagine, for some things that's relatively straightforward. For a lot of things, it's not. So there are obviously problems with, quote, best practices that we, as physicians, can try and solve. Obviously, the literature on anything in medicine is expanding all the time. I don't know the numbers. There are data out there that say how many new papers come out every year, but it's mind-boggling. For example, I went to a search on a search device called Ovid, not named for the poet, I don't think. And I just put in interstitial lung disease and diffuse lung disease together, and there are 5,500 papers. And even if I whittled it down by just saying kids, there were over 600. And these are only the ones that Ovid is going to pick up. They're going to miss a lot of them. So they're certainly far more than that. The difficulty is in defining and finding good studies. It's difficult to do that. People, humans, are not mice, and we're not like other animal models. Look around the room, we're all different, but we're all the same species. Last I checked. Well, I may not be, but never mind about that. And research, even by the very best physician scientists, who, by the way, some of whom you've heard at the meeting, if you attended it, even by the very best physician scientists with the very best of intentions, is often an imperfect thing. Research is imperfect. That's why the literature is always expanding. We're always behind. We're always learning new things. There are new techniques all the time. So what was true last month or last year, next year or next month for that matter, may not be true. So now there are a lot of these, they have journals, database services, et cetera, that can provide all these summaries of these studies to help the physicians figure out what to do. They're expensive, these particular devices, by the way. So getting back to what we're trying to do, this is what we're coming up with. And I keep saying it's going to happen, and it is going to happen. It's going to happen this year. It's going to happen this summer. We hope that it goes in, that the ATS will accept the practice guideline for the classification, evaluation, and management of childhood interstitial lung disease, or child in infancy. And this seeks, what we're trying to do with this is to help the pediatric pulmonary community mainly by providing this description of child entities and the steps involved in recognizing, evaluating, and correctly diagnosing them, even though we know that a lot of these, a lot of you know, we still don't have diagnoses all the time. So what can we do? What can we do to teach the pediatric pulmonology clinic, community about these entities? Well, how do we do this? What are the things that we should do? Well, first of all, we can teach them to realize that most children with diffuse lung disease do not have an entity of child. They don't have knee high. They don't have SPC. Most kids don't. Most kids have things like viral infections and aspiration syndromes or cystic fibrosis or something else. And their first job is to rule those things out. So as the first best practice, a physician who is faced with a child who has sounds and looks like someone with diffuse lung disease is to rule all the other things out, getting back to child syndrome. So that's what they have to do first. And we have to, and that's one of my jobs is putting a hand on the shoulder of my fellow who hears crackles in a patient and says, this is knee high. And I say, well, wait a minute, it's not knee high yet. You don't know that. There are a lot of other things you have to rule out. So that's my job at my institution, and that should be our job for our colleagues around the country. See if I can get this to move. What are some of those initial studies? Well, obviously, everything depends on the age of the patient, the speed of onset of the illness, the severity and progression. Those may affect how fast or slowly we do things in the diagnostic world. But the first thing for me, being a clinician, is a history and physical exam. And people who know me in clinic know that I'm relatively picky, or I like to say thorough, but then I say I'm just picky. But we get basic studies first. We don't go right to the infant PFTs. We don't go right to a lung biopsy. We have to go through things, jump through the hoops, and do the things we need to rule out these other entities. This may sound obvious to you, but to our colleagues around the country, it's not always that obvious. So like if aspiration is suspected, we'll do radiographic studies. If they need a bronchoscopy, they'll get a bronchoscopy. But you have to understand that for most of these entities, the child entities, bronchoscopy is not that useful. And I like doing bronchoscopies. I mean, I need the practice and I need the money. But that's what I tell my patients. I'm honest, that's right. But it can reveal infectious problems or bleeding. From my bailiwick, I will consider genetic testing, when I'm getting to the end of these studies, simply because it takes a while for those things to come back. And it's still not moving here, so I'm going to move this to the next one. There we go. And then after that, and only after you do if you jump through all the other hoops, do you get these other child-related genetic diagnostic tests, the genetic testing, the CT scans, the infant pulmonary function tests, and if it's still unclear, then we go to lung biopsy. So, and that's why I'm starting this off, because you're going to hear about infant PFTs and you're going to hear about lung biopsies. That's why I went first. Clinical suspicion in the case of all of your children was the first step in getting to the diagnosis. And I can't emphasize that enough. You have to have physicians who are inquisitive and not accepting of the status quo, if you will, because there are 3 diagnoses that even a good clinician will miss. And I've been plagued by all 3. 1, the diagnosis that, for example, that is unknown or I've never heard of. The diagnosis that I have heard of, but I didn't think of. Or the diagnosis that is known and thought of, but not pursued adequately. And I think what we're trying to do for everyone is to make this 3rd one, at least, less common, because we're going to try and get people to think of the diagnosis, to know what the diagnosis is, and then know how to pursue it. And with that, I'm going to quit and let Gwen take over. Thanks.
Okay, my name's Gwen Kirby. I'm one of the pediatric pulmonologists at Children's Hospital of Colorado. I work very closely with Robin Dieterding and Leland and many other people. And when I looked at the topic, one of the things I was going to talk about was infant lung functions, but I actually kind of stepped back to just talk about pulmonary function testing in general, because a lot of the things we do in older kids and what most people will call adult PFTs are actually very closely related to what we do in infants with some additional challenges. So why do we test lung function? Well, we measure lung function because we want to know how well the lungs work. And in infants and children's, children, we do this because we're concerned they might have lung disease, and we want to compare them to children that don't have lung disease. So there's fancy formulas in the computers we use that can tell us what normal children's lung function should be based on their height and their gender and their race and ethnicity. So we can compare any child that comes into our clinic for possible lung disease to normals. We also like to use lung function because we can follow it over time. It's probably actually more useful to compare a child to themselves than to compare them to everyone else in the population. So we can follow them over time to see if there's any changes. We can decide if they have lung disease at all based on this. We can decide how severe it is, and we can also see how it responds to treatment. So if we start a medicine or an inhaler or something like that, we can see how it responds. The major challenge that we have as pediatric pulmonologists and you have as parents is that some days this can be a little more challenging in our population than in adults because we have these challenges, which is, so I'm going to talk first about preschool and older kids and then in infants and how we do lung function in that group. So pulmonary function tests, the most common test you'll usually hear about is something called spirometry in adults and kids. Usually we can start at about 3 to 6 years of age. We've done some studies looking at preschool spirometry. It offers its own set of challenges because spirometry requires cooperation of the patient or child. And this equipment is available in most clinics and most hospitals that have pulmonologists, so it's pretty common to see it. Even some primary care doctors have this in their office. So it's kind of the most common pulmonary function that you see. And generally, just to give you an idea of what this is like, for those of you that have older kids, you may already have seen this, or if you have younger kids, you'll do this down the road. So this laptop has some software on it, and this is the thing that the child actually breathes into. It's called a pneumotach, and it has a filter on it, so we change the filter for each kid, and the child puts it in their mouth like this. This is actually from one of the company websites, and they usually try to wear a nose clip, which some kids think is kind of fun and can take home with them, and some of them are very unhappy about a nose clip. And this is the kind of software we use. So in order to engage our younger children and make it a little more fun and make their ability to do this better, we use software where they can blow out candles and blow down houses and things like that. And most of them find that to be a challenge. It's kind of like another video game for them. The spirometry, the child is asked to take the deepest breath in they can and then blow out as fast and as long as possible. We measure the amount of air in the lung and how fast it comes out. So we measure actually flow, and we calculate volumes and measure time and things like that. And the things you'll hear your pulmonologist or someone talk about are things called what we call obstruction, which is when the air can't come out as fast as we expect it to, and that's usually because the airways are smaller or narrowed or inflamed. Asthma is the most common time we see that, but some of the ILD, child diseases, patients have obstruction. We also see something called restriction, which is just that there's not as much air in the lungs, and we can suspect that by using lung volume testing, which is the next thing. So another part of PFTs that we sometimes use is lung volumes, and it measures the amount of air in the lungs. Usually a patient sits in, it can be done a couple different ways, but most commonly in kind of a plexiglass box. I was going to put a picture in here, but the only website pictures I could find were like old people in wheelchairs, so that didn't seem pertinent. But this can be done starting usually around 8 years of age. Some kids get a little bit scared because they don't like to be in a box, even though it's clear and you can see out. And this tells us a couple different things. One's restriction, less air in the lung, and one's air trapping, and that's when kids have extra air in their lung. They may still not be able to breathe all that air out. It may be kind of trapped in their lungs in a way. So what I really wanted to get to with that background is infant lung function testing. So we use very similar techniques with infants as we do for our older patients. But in infants, the challenge is that they can't cooperate and follow the directions and take a deep breath in when we tell them to and breathe out when we tell them to. So we use very specialized equipment. And this is available in probably 30 to 50 sites. In the US, it's actually available in a lot of international sites. There's a couple different companies that make this specialized equipment, but it's not something you're going to find in every community. The way we do this is we give them usually an oral sedative. It can sometimes be IV, and that helps the child sleep. And while the child is asleep, we can passively give them deep breath in and help them breathe out. Generally, you'll be asked to keep them awake for a period of time before the test because we need them to be asleep. And if they're tired or ready for a nap or something, that usually takes a little bit less sedative. They can't eat or drink anything before the test for a period of time, and that's because of the sedation. And once they're asleep, we can measure their lung functions. This isn't done under general anesthesia or something like when you have a surgery or a biopsy or something, because we want them to breathe on their own. We're trying to measure how they breathe, so we don't want to be breathing for them. So the key to this test is just that the child has to be asleep. If the child isn't asleep, then we really can't do the infant lung function test. And I'll show you some pictures in just a minute because I think that makes it easier to understand. But once they're asleep, they're placed in a cradle that's in an infant PFT machine. There's a mask that goes over their nose and mouth, and usually there's some putty around that because we want to be able to measure all the air that's going in and out. And we want them to breathe on their own. We can give them oxygen during this test. It's usually the machine is hooked up to the wall, oxygen and air. And we always monitor them the whole time they're getting this test done. They're monitored usually for their respiratory rate, how fast they're breathing, their heart rate, their oxygen level, pulse oximeter, like many of you are familiar with, and also usually carbon dioxide level throughout the test, so we know that they're doing fine. And once the sedation often takes as long as anything, and once the testing begins, usually this is less than an hour that it takes to do the test, and often if everything goes well and they don't wake up or there's no technical issues, it can be even 30 minutes or so. It depends. Sometimes we only do certain components of the test, but mostly we do them all. Sometimes you will see us try in adult spirometry or an infant to do it the test and then give them some albuterol and do more of that test. So the things we measure is tidal breathing, and that's how fast and how deep the child's breathing in and out. The lung volumes that we talked about before, like in the older kids, which is how much air is in the lung. The spirometry is how much and how fast the air moves through the airways. And this is kind of what makes infant PFTs somewhat unique, and is that because they can't take a deep breath in and breathe all the way out, what we do is we give them some deep breaths, and young children will pause in their breathing after you do that. And when they pause, we give them a big breath in, and then we have a vest around them that squeezes the air out. So basically, we're making them do what we would ask an older child or adult to do. Some of our ILD patients are a little more challenging to do that because they already breathe very fast, and actually they breathe very fast and they don't want to pause in their breathing, which is a good thing. But it makes it a little more challenging sometimes to do their test because you need that brief pause so that you can get all the air out. And then we do pulmonary mechanics, which looks kind of at the stiffness of the lung. So this is a picture. I don't think there's a pointer here, but this is a picture of our infant PFT equipment. This is one of the first types of equipment that's in the U.S. There's another one that's also here now that looks slightly different. But basically, and this is not an ILD patient, it's actually a patient with a chest wall deformity. And so this patient lays in this cradle here. This child's asleep. They have this mask over their nose and mouth to measure all the air with a little bit of putty around it. And then this equipment here is what measures the amount of air and how fast it's going in and out. And the computer obviously is measuring all that, recording all that, and then it's also where we tell it which part of the test we're doing and when to start giving them the extra breaths and when to squeeze and things like that. But this is basically what it looks like when you're doing the tidal breathing. When you do the lung volume part, this part just slides and it makes kind of a seal here. They're always breathing through this, so this is where the oxygen and air and everything comes in. So even though the box is kind of sealed, they're still breathing through air that's coming through that circuit. And this is what it looks like when they do the spirometry. So we give them the deep breaths in here, and then this is a vest that goes around their chest and abdomen, and there's a little bladder in here that's connected underneath the machine, and what we do is when we want them to breathe out, we fill this bladder with air, and we give them the deep breath in, and then it inflates kind of quickly, and they just breathe all the way out. So that's really how we do that test. And we always explain all this to families in advance. This part of the test is kind of, they breathe out really fast, and everyone's kind of surprised by that part of it. So we always tell them all about it. And then also for our lab, we generally will let families stay or leave, whatever they prefer to do. We just explain to them what we're going to do beforehand so that nothing's really a surprise to them. So we look at a lot of different numbers, and actually I didn't go through all the different numbers that we look at. I actually wrote kind of a one-page thing for the ILD newsletter. I looked back, I found it was about 2006, and it goes through all this and actually has a little more details about the different numbers we look at and what they mean. But we also look at these things called flow volume curves or flow volume loops, which just has flow and volume here. And this is a normal child. It generally looks kind of bowed out. This is a child with cystic fibrosis. We do a fair number of those, and it has a little bit of the scooping here at the end. And then for some examples of interstitial lung disease, for example, in knee high, you also see some of the scooping, which goes with obstruction. And actually, this is usually a lot more dramatic in the knee high patients compared to maybe a cystic fibrosis patient. Sometimes it's a little similar to some of our children that were born early that have BPD. And then this is an example of a patient with SPC. You can't really appreciate it quite as well, but it's actually kind of taller and narrower, and that's for more of a restrictive lung disease. So these are the things we use, and this allows us to kind of classify when we have a child that we think has some kind of ILD. This might help us say which, are they looking more like knee high or looking more like a surfactant protein mutation? Sometimes we can help narrow down the number of diagnoses we're looking at by using PFTs in infants as well as obviously in older kids that we see in our clinic pretty regularly. So after the infant PFT, we watch the child until they wake up. Some kids wake up really quickly. Some of them sleep for a while. After they're awake, they can have something to drink because they haven't had anything to drink before because of the sedation. They are kind of sleepy and groggy. They tend to have their balance isn't as good for the rest of the day usually because of the sedation medicine. It doesn't go away quite as quickly as some other medicines. And that's basically a summary of what we do, what PFTs are, and what we do when we do infant PFTs. So I can go ahead and let Megan go, and then I think the three of us can take any questions.
My name is Megan Dishup. I'm a pediatric pathologist. So my training has been in gaining expertise in diagnosing disease in children. And my specific interest is in pediatric lung disease. And even more specific than that is looking at diffuse lung disease and interstitial lung disease. So my area of expertise is in looking at lung biopsies, and that's what I wanted to tell you about. I know that not everyone gets a lung biopsy in the workup, and that's obviously a good thing if that's not needed. There's a lot of testing that's done in anticipation of my role in the process. So once the blood testing has been done, the history and physical, maybe a sweat test, for example, to rule out cystic fibrosis. The CT scan has been done. You might have gotten a bronchoalveolar lavage to look at the lung fluid and those components. At some point, sort of late in the diagnostic process, you might be asked to consider a lung biopsy. So that's what I want to tell you some things about and how I look at lung biopsies and the kinds of information that we can get. There are some differences in how we consider pediatric lung biopsy as compared to adults. A lot of adults will get transbronchial biopsies, putting the scope down the airways and then using a tiny biopsy forceps to get very small 1 to 2 millimeter pieces of tissue. And we really don't use that very often in children and opt instead for a wedge biopsy, either through an open surgical procedure or through a thoracoscopic procedure where there are little ports put into the chest wall to take a piece of tissue. We have to use the wedge biopsy in most cases because we're trying to assess what lung architecture looks like. And there's a lot of other ancillary studies that we do on a wedge biopsy that just simply couldn't be done on a transbronchial biopsy because of the small amounts of tissue. And so what I wanted to show you was our algorithm that once the surgeon takes the biopsy and they send it down to the lab, and I'm one of those people in the basement of the hospital, what we see in the center is a representation of the lung tissue. My job is to divide it and make the most out of it. So we will take portions for culture. While there may have already been cultures done from fluid and from blood and that sort of thing, we also take it from the tissue because it's another chance to sample that and make the most out of the biopsy. Sometimes we'll do touch preparations, which is where you dab the tissue onto slides, and that gives you an opportunity to stain for organisms also. We always take a little piece of tissue for electron microscopy. This is a special fixative called glutaraldehyde, which helps to fix the ultrastructure of cells so we can look at things like lamellar bodies within the type 2 alveolar epithelium. That's really important for the surfactant disorders. And because we don't know which ones are going to be surfactant and which ones aren't, we always do that. That also offers us a real opportunity to learn about disease going forward also. We also freeze tissue, so we'll take a little piece of the biopsy and freeze it in what's called a bullet or a little vial that we can store that, either to bank it for other diagnostic studies like the molecular and PCR studies that Dr. Hamvis and Nogi do, or maybe for other kinds of molecular microbiology, looking for organisms by that method. And then would also be available for research studies in the future with consent. And then we also freeze tissues in a compound called OCT, which lets us do a study called immunofluorescence. We don't do that all the time, but for babies and children that are having pulmonary hemorrhage and we're worried about a vasculitis, that's where we might use that study to look for immune proteins. And then the most important, and what I find the most useful, is at the bottom, the histology. So we'll take the remaining part of the lungs, once we've done all those other things, and use injection inflation to fill it up and fill up the air spaces, just like air would fill those air spaces in vivo, in life. Once the biopsy is taken out, they often get squeezed back down. So we re-expand it with a fixative fluid so that we get nice open air spaces and can look at the architecture that way. We put it into these little cassettes, and then it goes through an overnight process, and a wax block is created out of it. So this just shows some of the expansion that we do with fluid to recreate the air spaces down at the bottom. And so what I wanted to go through next was just showing a few examples of various disease processes. I go through kind of an algorithm in my own mind of what I want to look for, and there's a lot of information we can get from these biopsies. We look at airways, we look at the alveolar spaces to see what's filled inside, we look at the interstitium or alveolar walls, and we look at and then we can look at the vasculature, the pleura, and the interlobular septa. So I look at all of those things as I approach each case. So some of the things that I can look for specifically would be to look at the small airways to see if there's a bronchiolitis or whether there's airway fibrosis, like bronchiolitis obliterans syndrome. And so that's something that, as we've discussed, can often be detected either by culture studies for bronchiolitis or looking at the chest CT patterns. Oh, thank you. Oh, okay. Did you use this? Okay, got it. Thank you. If the bronchiolitis obliterans hasn't been detected by chest CT, or there's uncertainty about it, sometimes we'll pick that up on a lung biopsy. The other thing we'll look at is what's in the alveoli, how the alveoli